Good afternoon. Thank you for the introduction and thank you for the opportunity to present some of my PhD work. My PhD is a collaboration between the University of Leiden and the University of Reykjavik. So my opening slide should look like this. In the 10 to 15 minutes of this talk, I'm going to present some projects of my PhD, which all circle around ROP. Why to do retinal oximetry in children? Well, the oxygen plays a major role in several diseases in children. Disease is one example. It's a rare disease, but the point with Coats disease is that there's one affected eye and one healthy eye, which makes the comparison quite easy. Also in retinopathy of prematurity, which is oxygen plays a key role in it. We're doing some work in what older patients who had treatment. You can see a 7-year-old girl who had some laser ablation during her early childhood due to a stage 3 ROP in both eyes. ROP is an abnormal development of the vessels due to prematurity. It usually happens when babies are born before 32 weeks of gestation. Usually the full vascularization occurs around week 40. It's an avascular retina, and as Professor Steffensen told us yesterday, this avascular retina causes hypoxia, which causes in the end the VEGF and works its way through neovascularization. Current theory is that there's a two-phase approach to ROP. The child is born and it comes into a very rich oxygen environment, which then seizes the blood vessel development in the retina. However, the retina develops and the metabolic need supersedes the supply of oxygen by the vessels. When that occurs, you get a hypoxia, which results in VEGF and neovascularizations. It's a vision-threatening disease, so the treatments are keen on reducing the VEGF load, either by targeting higher targeting saturations, either laser dioxide to destroy the retina, to reduce the oxygen need, or by using anti-VEGF injections to stop the process of the ROP. This means that there needs to be a lot of screening, and it's preventable. So the screening techniques are either indirect ophthalmoscopy or screening with a camera. The most used camera is a RedCam, which makes contact to the eye. It's not a pleasant procedure for the child, as you can see. It's quite a harsh procedure, but we need to do it to prevent the child from losing their sight. So 2 years ago, my supervisor, Nicoline Belay, proposed that retinal oximetry can have its benefits for this at-risk population, because we can now measure in the eyes if the blood correlation between the retina and the periphery matches, either or the effect of the oxygen treatment has its effect within the retina. Is it a predictor for disease? Can we prevent it by stepping up the treatment a bit? And the beautiful part of can it be non-invasive, so we can get more screening attempts with it. Can we optimize the indication, the timing, the dosage? So there might be a big role for retinal oximetry. To take a step in that direction of making retinal oximetry available for infants, we did a study in Reykjavik to assess whether retinal images obtained by a scanning laser ophthalmoscope are suitable for retinal oximetry in full-term infants. For this study we used full healthy neonates recruited at the pediatric department of the Landspathology, and we used an OPHTHALMOSCOPE 2x200 from Optos. We used a Resmax 200 of 100 degrees setting for the analysis of the analysis with the modified Oximap analyzer software, which the images were obtained by using the flying baby position, which more or less means that we're holding the child's head in the machine. We had the analysis of the vessels. We took the supratemporal vessel pair and we measured until the first branching, which had to be longer than 50 pixels. If that was not the case, we measured the second branching. The results were that we included 59 patients. We had to exclude 4. We included 55. We got 250 Resmax pictures, which we had to reduce to 28 images that were selected for analysis. Our male-female were quite equally distributed, and we had a mean postnatal age of 16 days. We wanted to present our data in the ODR, which you can see on the x-axis, and the y-axis, and on the x-axis you can see the subjects. You can see there's a quite high variability within the venules of the patients. The ODR is significantly different, but there is still a few steps to be taken. We see a high variability. The image quality to obtain is quite difficult. We didn't use any invasive means like an eye speculum or mydriatic drops, so we had to keep the eyes open by hand. The neonatal eye is a bit different from a adult eye because it's smaller, it has a higher density vitreous and low pigmentation. Therefore, as well as that the ODR was a bit higher in comparison to adults, and this is why we chose to use the ODR and not the saturation, because the calibration factors are only applicable in adults. We need to do some further testing to make these calibration factors known for children. However, the OPHTHALMOSCOPE 200 is not very practical in neonatal care. It's a huge machine, it's loud and noisy, and you can't take it into the neonatal intensive care unit. So there was a problem. Therefore, we wanted to create a camera which had the dual wavelength oximetry, which we can use for screening purposes and which was applicable in neonatal care. So we collaborated with a number of groups: the Leiden University, the Landspathology in Iceland, Focal in Enschede, Demcon, which has a very good collaboration with Focal, and Oximap. And we started this process, and we came to Focal and said, well, we want a camera that's mobile, it's handheld, we wanted to have 2 cameras, and we need to take pictures in the neonatal intensive care unit. It also means that you can't apply it to the mains, or have it needs to be medical grade. Well, as a medical doctor, it's always the engineering is a lot harder than you think, and Focal made a scheme of how every part of the camera would be have to be assembled. So here we can see the light box, which was custom built for us, the cable, which consists of fiber cables, and a measuring head, which allows us to take non-contact fundus images in patients who are suspect. So the light box was customly engineered for us. We're using a light source for infrared live imaging, which consists of a near-infrared LED of 80-60 nanometers. We're using xenon flashes for illuminating the eye, and spectral filtering similar to the Oximap T1 in 570 and 600 nanometers. To get the light to the handheld unit, we're using 12 fibers. 4 are reserved for the infrared, and the other 8 are for the xenon flashes. The optical part was evolved from a fence camera focal had already developed in an earlier project. So, well, they adapted that. And these were the first images we took. We had to manually change the filters between the flashes, and we had to hold the camera for a few seconds before taking the second picture. However, we were quite pleased when we got the result back from Oximap that we were measuring oxygen within the retinal vessels. So we were at that point on the right track. These results are quite new, which means we're taking a full 30-degree image, which we can see the oxygen saturation quite clearly. Another big part of this image is that it was taken in a non-dilated eye. So we didn't use any dilation or whatsoever. At this point it was all mounted to a chin rest, which made it quite easy for us to align the pictures with the retina. However, we wanted to have a handheld device, and we wanted to use it on premature babies. And that was also quite of an engineering problem, because we had to have 2 cameras and we had to have the optical cable in the device as well. So we're using a handheld device. This is the focus adjust ring, so we can focus. This is the part where the illumination comes into the camera. This part is to keep the camera maneuverable while you rest your hand on the head of the child. This is what we got in a kind of a test setup with one of the engineers trying to perform this test, and we've managed to take reasonable pictures at this point. We were quite pleased with that. This is how it's going to look. Perhaps we could glue the housing, but that's a minor detail. But we've managed to put it in and mounted it on a chin rest, and we're looking forward to perhaps bring you some results in 2 years to see how the camera is performing. So thank you.